Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each individual presentation will be followed by its own Q&A. Use the chat feature to submit your question. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now I will turn it over to our first speaker.
Well, hi everybody. It's nice to have you all joining us here today. I am Lance Gable. I'm an associate professor of law at Wayne State University in Detroit. And my topic for this session is going to be looking at legal issues related to government use of authority in responding to the COVID-19 pandemic, and particularly focusing on restrictions on movement, restrictions on business and school activity, so closures of schools and businesses, and also other issues that came up in terms of restrictions on gatherings and people interacting with each other. And so I'm going to put on my slides here and get started. Okay. Just bear with me for 1 second here. Okay, this should be seeing them now. Okay, so to get started, I just wanted to provide a bit of an overview of what I'm going to cover in this discussion today. I'm going to focus on how government powers were used in the first few months of response to the COVID-19 pandemic to restrict movement and activity. And as we'll discuss, there were numerous ways in which government powers were used to try to limit the interactions between people, especially at the earliest stages of this pandemic, when we were doing everything we could to flatten the curve and make sure that the outbreak did not get out of control and overwhelm our capacity, our healthcare capacity, beyond what it could handle. I'm then going to turn to looking at some of the legal challenges, and there have been also numerous lawsuits and challenges to the use of government powers in this way. In a lot of senses, this time has been quite unprecedented, not only in the scale and scope of the risk and threat that we face from this pandemic, but also in the ways that government power to protect public health has been used in putting very widespread restrictions on what people could do, in ways that not only were things that people were not used to or not expecting, but in ways that really generated quite a lot of political controversy, and of course generated quite a lot of legal challenges. And so I'm going to focus on the content and the outcome of some of those challenges, with the realization that many of them are still ongoing. And then I'll finish off with some of the recommendations that I put forward in the chapter on this topic that comes from the larger report, which you should all know about at this point. The report is Assessing Legal Responses to COVID-19, came out about a month ago, and was the product of the work of nearly 50 authors, over 36, or actually exactly 36 chapters, focusing on all sorts of different aspects of the COVID-19 legal response. If you haven't yet seen the report, I would strongly encourage you to check it out. It has a lot of really helpful information. So let's start here. And while I assume, since this is the Public Health Law Virtual Summit, that most of you are familiar with public health law and have a background and understanding of some of the basic approaches and uses of public health law, I did want to provide a little bit of background even before we get to the discussion of how powers were used during COVID-19. So generally speaking, both federal and state and local governments have quite extensive powers to intervene in order to protect the population's health. And so at the federal level, in fact, at the federal level, the powers are somewhat less broad than they are at the state level, but federal powers are still quite extensive in certain types of circumstances. And so the federal government is empowered to use its authority to control entry into the country and also potentially travel between states. So travel restrictions and entry restrictions, including immigration laws and including just rules about who can enter the country as a traveler, are well within the scope of the federal government. The federal government's powers can be broader than that as well, But as you'll see, so far, the vast majority of movement restrictions that were put in place in response to COVID-19 came at the state level rather than at the federal level. On that point, state and local public health powers are extensive, and there's an extensive history of courts and courts finding that state public health powers are broad enough to encompass a whole wide range of initiatives that are determined to protect the health of the population. And so, for starters, obviously states have powers to quarantine and isolate people. I'm not going to be addressing that in my talk today. That is actually covered in a different talk, different chapter in the report that Ross Silverman wrote, and I would encourage you to take a look at that if you're interested in those topics. I'm going to focus more on the initiatives that were implemented at the population level to stop interaction between people. So this includes mass movement restrictions, business closures, and school closures, also gathering limits and conditions being put on gatherings. So limits would include rules about the number of people that can get together in any particular place for any particular amount of time. But gathering conditions might include things like mask requirements and other kinds of precautions that people are required to take. And so, one fundamental initial point that it's important to note is that there are over 100 years of case law that very strongly support the idea that state public health powers, the state police powers, are broad enough to allow the state to take actions of these types. And so you have cases going back in the late 1800s and early 1900s where states were found within their rights to restrict movement, restrict interaction, and also to close down businesses that pose the threat to public health. And so that's the basis on which a lot of the current jurisprudence is being based. I'm also going to talk about Jacobson versus Massachusetts, which is sort of the primary Supreme Court decision that's often invoked when this issue comes up. I'm going to talk about that a little bit later on in my remarks. So one big takeaway in a general sense here is that government authority is subject to some constraint. Government can't just enact any kind of restriction it wants to if it's not justifiable. But the bottom line is that this power is quite broad, and as we'll see when we talk about some of the examples in the response to COVID, courts have continued to uphold and recognize this broad power. Another important component of the legal landscape here is that governments at the federal level and at the state level have broad emergency response authority that they can invoke to implement these intervention strategies rapidly in order to intervene to stop the spread of a dangerous threat to the public health. And so, so that's where we're going to start. Now, if we apply these general approaches to COVID-19 and we look at what actually happened with the response to COVID-19, what we see is that, at least in terms of movement restrictions, at the federal level, most of the federal action in this area occurred with regard to travel restrictions. There were entry restrictions on travelers from China, from some parts of Europe, and some other countries as well. And then there were also restrictions placed on people entering through immigration laws and other provisions. But the federal government could potentially have engaged in even greater effort to intervene to stop the travel of people between states. Arguably, that would be within the federal government's power to constrain interstate travel to prevent the spread of disease. The federal government did not go there, and that's an important thing to note as well. Another area where the federal government had a lot of influence, though, over movement restrictions and closures was just in the guidance that federal agencies issued in the first few months of this outbreak. So the Centers for Disease Control and is the primary agency that was offering guidance for when it was safe to open or not to open certain kinds of settings. And that guidance was very influential on state and local decisions about what was permissible in their states. But at the same time, you also had guidance from Department of Labor, Department of Education regarding workplaces and schools that also had a lot of impact. The big problem with the way this was implemented, though, is that at the federal level, even though some of the agencies were coming out with guidance designed to help people in positions in state and local governments, and even in just individual institutional settings or businesses, make decisions about whether to stay open or not. That guidance was subject to contradictory statements, often from the president, and the politicization and a lot of the confusion that created has made the guidance coming from federal agencies a lot less straightforward to follow. And then, of course, there were some federal actions that were in opposition to state efforts to close down certain businesses to protect the well-being of the workers, including use of the Defense Production Act to compel meat packing plants to remain open during the initial stages of the outbreak. Now, at the state level, by the middle of March, every single state had already declared an emergency related to the COVID-19 outbreak. And as the cases began to mount and as the systems began to adapt to an influx of patients, especially in the hardest hit areas like New York City, you start to see states engaging in these intervention strategies, restricting movement and closing businesses and schools, limiting gatherings to a small number of people. And it was a rapidly moving target. So just as an example, New York State on March 12th placed a restriction on gatherings greater than 500 people. Only a few days later, I think it was the 15th or the 18th of March, that number was reduced down to 50 people. And then on March 22nd, no unnecessary gatherings of any sort were permitted in New York State. And so as the scale of the outbreak began to become evident to policymakers and lawmakers at the state and local levels, we start to see a rapid ramping up of these restrictions to the point at which the vast majority of states around the country imposed some sort of restriction of this type. Now, it varied quite a lot. So there are some states that never went beyond having either more voluntary gathering size restrictions or imposed restrictions of 10 people or more gathering, but had lots of exemptions, including exemptions for religious gatherings and other kinds of settings. And so the policy choices occurred in this context. Also, local governments enacted some of their own restrictions on movement and gathering and business closures. In some cases, these restrictions were in opposition to what was going on at the state level. And so this ended up, in some cases, being leading to tension and controversy. So I know my time is going rapidly here. I thought I had a bit more. So what I'm going to do is I'm going to move ahead and talk a little bit about some of the challenges. I should mention this before I get to the legal challenges. The movement restrictions do seem to have worked to flatten the curve. And in jurisdictions that were more aggressive in imposing restrictions, the rates of infection decreased more quickly and have stayed down longer if the jurisdictions have remained restricted longer. And so again, it's hard to have direct cause and effect causation with that sort of conclusion, but it does seem like jurisdictions that were willing to keep the restrictions in place longer have had better results in keeping the rates of infection down. And it's really important to note that economic and social supports that were put in place by state and federal government during the course of those early months were essential to allowing people to stay home. The income support, the moratoria on evictions, and a lot of the other really important policy decisions that were made helped people comply with those restrictions in a way that didn't completely undermine their ability to survive. And so now, and another important point is that while these restrictions were being put into place, the capacity that we should have been building up was not sufficiently built up, and that's a big failing of the results of this situation. Even though it flattened the curve, it didn't. We didn't take the steps that we needed to invest in the kind of support structure that we really need going forward to avoid having to do this again. Okay, so let me just quickly talk a little bit about the legal challenges. So legal challenges here, there were numerous challenges filed to movement restrictions and business closures. They came from businesses themselves, from individuals, institutions, including religious organizations who didn't like the fact that religious services were being restricted by some of the gathering size limits. And even some cases brought by legislatures against executive branch officials, claiming that those executive branch officials exceeded their authority. The legal theories were also very varied depending on the suit, and so a lot of the cases invoked fundamental rights violations, including First Amendment rights to assembly and free speech and free exercise of religion, but also due process and equal protection claims based on the impacts of the decisions on either individuals, businesses, or institutions. And so one big takeaway from the legal challenges so far is that courts have not, while courts have not adopted all the same legal reasoning in analyzing the challenges, in virtually all of the cases, the state has prevailed in, and courts have upheld the state's authority to implement these restrictive measures. And while there are a few notable exceptions to that, generally speaking, what the early litigation in this area has shown is that the deference that courts show to states in implementing their police powers to stop a public health threat remains pretty consistent across the board. The couple of areas where there were successful challenges to state powers, there were a few cases where religious organizations were successful in challenging state laws that didn't allow religious gatherings, and there was an allegation that religious organizations were being treated differently from secular activities, and invoking First Amendment free exercise protections. In those cases, in a few of those cases, the court said that the state had to modify its restrictions to allow for some religious activity, although not necessarily abandon the restrictions altogether. There were some other cases, including two that went to the Supreme Court, where religious organizations didn't prevail, where the state allowing certain secular activities but not allowing religious activities was upheld as a rational exercise of state power. And of course, anytime you talk about constitutional analysis of public health powers, you have to analyze the Jacobson versus Massachusetts case. Some courts have treated that precedent as requiring extreme deference to state action during public health emergencies. Other courts have found for the state, but found that there should be some additional consideration of constitutional rights. And some states have, or some courts have gone, have just applied normal constitutional scrutiny analysis to evaluate state public health powers and not given additional deference related to Jacobson at all. I can talk more about that if people have questions. But I want to round this off by focusing on actually two final points. One is that in all of these different kinds of legal challenges, it is notable that the state prevails, across multiple jurisdictions and multiple types of legal challenges. The two exceptions that I wanted to point out that are notable are cases that involve, one of them involves a legislature challenging the executive branch's authority to promulgate these types of movement restrictions. That happened in Wisconsin, and the Wisconsin Supreme Court found that the state action by the executive agency, the Department of Health, exceeded the scope of delegation under state law to that agency. So it basically said the state agency couldn't make that kind of restriction, couldn't impose that kind of restriction based on its authority. Butler v. Wolf, and I see there's a question about this as well, the Pennsylvania federal court decision that found just 2 days ago that the state's orders closing businesses and also imposing a stay-at-home order were unconstitutional. That is a real outlier, and it'll be interesting to see whether or not that case is kind of a window into where courts will go in the future, or whether it ends up being an anomaly. Just really quickly, what the judge in that case found was that the imposition of a stay-at-home order by the state of Pennsylvania and also the closure of businesses were constitutional violations, that the stay-at-home order violated freedom of assembly provisions of the First Amendment, and was a substantive due process violation, of the ability of individuals to gather, and the court applied intermediate scrutiny to come to that conclusion. And then the court also found that business closures were a substantive due process violation based on a fundamental right to earn a living, which is a phrase that is surprising, I think, to a lot of constitutional law scholars. The court seems to believe that Lochner has not been overturned and seems to be moving back in a direction where economic activity would receive constitutional protection against public health regulations and efforts to try to protect the health of the population. There is this balance to be drawn somewhere. You know, obviously, emergency deference cannot go on indefinitely, cannot go on under any circumstances. And I think as we move forward and have greater understanding of the risks that this disease poses, how to prevent the spread of the disease, some of the broad, widespread lockdowns are less justifiable based on the science, because there can be more targeted intervention. Part of the problem, though, is that we have not yet develop the kind of capacity to test, trace, and isolate that we would need to do more targeted interventions. And so I foresee that there could be cases coming down the road where these challenges are a bit more successful because the broad, across-the-board restrictions on and business closures and movement restrictions might no longer be as justifiable as they were at the outset of the pandemic. So I'm going to stop now, and I'm going to turn it over to Professor Terry. Let me stop sharing my slides, and I'm going to turn to him, and we'll take it from there. Go ahead, Nick.
All right, that should be up. Thank you all for joining us. I have to say, just very quickly, thanks to Brother Gable there and all the other editors on the project, Scott Barris, Wendy Parmet, Sarah de Gia, and Donald Levin for all of their amazing work and inspiration, and also to the staff folks who helped us out with the editing and everything. Extraordinary piece of work in a very short period of time. While Lance was giving you a public health primer and then going deep, I'm going to concentrate on giving you a flashback to first year torts before talking about the various statutory interventions that we have seen. There we go. The sort of lawsuits that we're going to be discussing that are coming to pass, the potential defendants, during sort of the first peak of COVID, we're basically talking about emergency departments which were overrun. Patient care was threatened by shortages of staff, PPE, ICU beds, ventilators, and so on. And some providers, many of whom were practicing outside their usual specialties, reportedly used improvised equipment, even prescribed untested drugs. Hospitals arguably themselves had failed to have sufficient equipment, PPE, and so on. So there's potential liability there. As hospitals reopen for routine care or elective surgeries, then non-COVID patients face the risk of COVID-19 as a hospital-acquired infection. I think we'll see some cases like that. Essential businesses that stayed open during the first peak clearly endangered their workers while benefiting those of us who were safely at home. And so high risk, the employees of high risk, the employers of high risk industries, meatpacking, warehouse fulfillment, and so on, may have some exposure. Nursing homes, of course, are much in our minds when it comes to both litigation and also a poor implementation of existing standards. Please see Tara Scar's wonderful chapter on nursing homes in the book. The basic idea: failure to isolate residents with symptoms, suboptimal staffing, lack of PPE again, and so on. And then most recently, medium to high risk businesses doing their reopening, restaurants, gyms, personal care services, schools, colleges, and of course, everyone's future favorite defendant, Greek houses. The liability theories here are, and here we do have the flashback to 1L torts, are pretty simple, really. Most of these lawsuits are going to be basic negligence cases, failure to act with reasonable care in all the circumstances. It'll probably be an ordinary negligence type of case, posing the likely jury question of reasonable care. Cases brought against healthcare providers, clinicians, hospitals, skilled nursing homes. They may get a medical malpractice characterization and therefore turn on expert testimony as the professional standard of care. Nursing home cases, I think, are particularly interesting because the common law claims will be fortified by alleged breaches of state or federal regulatory standards. And also you have the real potential here for False Claims Act claims, which are often driven by whistleblowers and have extremely strong damage results in many reported cases. And of course, because the government would be involved if it accepts the qui tam claim, there is the potential for the death penalty, Medicare and Medicaid no longer being applied. Obviously, we're mainly talking about Medicaid. A few cases will be brought alleging intentional or willful actions. I guess a few of those might pattern after some of those cases from the days of HIV/AIDS, initial exposures with intentional exposure arguments and so on. But I think most of the intentional willful actions will actually be attempts to trigger exceptions in liability shields, and more of that later. Barriers to these kinds of cases, well, they're not easy cases to win. And I think that's one of the big takeaways. Viral transmission remains possible even where reasonable care is taken. And so proving causation is really problematic. Where you've got concurrent causes, multiple comorbidities, I think there's going to be real proof problems for plaintiffs. There are some more technical objections or barriers as well. So nursing home admission contracts frequently include binding arbitration clauses barring lawsuits. Healthcare providers have long benefited from state legislative damage limitations, particularly on pain and suffering damages. And of course, going back to our workers in meatpacking and so on, workers' compensation laws create an immunity against negligent employers. And that's why we're seeing some sort of novel theories playing out there, such as public nuisance, right? Everyone's favorite claim from the opioid litigation, now getting another place to operate in. You probably read about the McDonald's case and a few others there. Pre-COVID, we already had shields. The PrEP Act of 2005 applies to covered countermeasures. There were some questions as to exactly what that would apply to. I'm not sure I really understood the issue, but the Families First Coronavirus Response Act tweaked that act slightly to make sure it applied to some of the PPE and other issues. We have had our first decided case in this context. The Maglioli case is a nursing home case, and the defendants tried to use the PrEP Act to establish preemption and remove the case to federal court, and lost on both arguments. The VPA of 1997 immunizes volunteers who work for nonprofits or government entities. And the CARES Act introduced a companion broader immunity for volunteering healthcare professionals, which did not depend on the non-profit status of the workplace. And one that I think is probably going to be the shield that we will want to discuss in a couple of months at great length is the National Childhood Vaccine Injury Act of 1986, which shields manufacturers and provides a no-fault compensation scheme for those who suffer vaccine-related injuries. And as we figure out how to incentivize vaccination, I think that's going to be a really interesting model. At the state level, the State Emergency Powers Act does have a sort of a rudimentary immunity or shield protecting private actors who render assistance or advice at the request of the state. But my interest was in novel COVID shields. And the first area I looked at were healthcare provider shields. If you look at this, there were 8 brought in by statute, 11 by executive order. These raised several issues, just how broad are the defendants, potential defendants covered. So for example, healthcare providers, clinicians may be covered, but were nursing homes covered? And about 50% of the did actually apply to nursing homes, you would think. Most contained exceptions for willful and wanton conduct, gross negligence in places. Probably the most difficult legal issue that these pose is sort of the causation question, or if you like, the arising from question. To what extent did the injury and the alleged wrongful conduct arise from COVID, or did it just happen to occur during COVID-19? And you could see there's some really difficult questions interpreting some of the executive orders and statutes with regard to that issue. A sort of related issue is how long do these things hang around? Obviously, the ones that are tied into executive orders are arguably going to expire along with the executive order. Some of the statutes have a broader time frame. Probably one of the most interesting statutes, it came very early, was the New York Public Health Law 3081-2. This was the sort of broadest first wave immunity reportedly drafted by healthcare provider and nursing home lobbyists. Has an extremely broad immunity for healthcare professionals, facilities, nursing homes, and even healthcare facility administrators and executives. It went to diagnosis, prevention, or treatment, and the care of any individual who presents at a healthcare facility during the period of the COVID-19 emergency declaration. So hence my arising from question earlier. That was too broad for the New York legislature. And in July, they partially repealed the immunity, restricting it to a narrower range of facts. These sort of healthcare liability immunities were very much, I think, tended to track the first wave. You could see from the map earlier that they tended to cluster in the Northeast. That's at the time when you saw volunteer providers pouring into New York and so on. And since then, the healthcare provider shields, we haven't seen much activity. There are a couple of exceptions. On one side, the Ohio House Bill 606, which was just signed by the governor last week, has a broad civil immunity given to the healthcare community. But on the other side of the fence in Michigan, there was Governor Whitmer vetoed Senate Bill 899, which had continued the earlier executive order immunity. There are some rumors that Connecticut is next to maybe rescind the coverage of nursing home immunities by its shield. And so on to reopening shields, which I think is the issue that people are discussing most at the moment. Here again, the geographical distribution is kind of interesting. On reopening shields, we've seen very little interest in the Northeast, very little interest in blue states, Illinois being an exception there, to get involved in these kinds of immunities. Instead, we've seen a sort of a broader swathe through plains and also through the Sun Belt, which are protecting immunizing. The other trend here is these reopening shields tend much more to be statutory, with very few being executive orders, which flips from the healthcare provider ones. Here, again, we have scope issues. For example, Louisiana's number 305 statute only applies to restaurants. Others have much broader language. Again, we have causative issues with regard to just how they have to be tied to COVID-19. And I think increasingly, the question of the intersection of an immunity with compliance or non-compliance with federal, state, local rules or guidances, which will be particularly important. As to statutory language, you just get really sort of simple kinds of statutes like the Utah one: a person is immune from civil liability resulting from exposure of an individual to COVID-19 on the premises owned or operated by the person or during activity managed by the person. The Ohio statute is more complex. It provides a qualified immunity to persons sued for causing harm. It prohibits class actions. It creates a presumption that government orders, guidances, and so on are not as admissible as evidence, and that they don't create a substantive legal right. So no negligence per se kind of approaches to liability. You probably have been following the activity, or should one say the inactivity, in Congress. The majority leader's line in the sand from early on, post-CARES, was that any new stimulus bill had to have liability protections built into it. The safe to work provision, which has been put forward by the GOP, is retrospective. It has an exclusive remedy for COVID-19. There is a clear and convincing evidence standard, not the usual probability. There's a 1-year statute of limitation, safe harbors for business that make reasonable efforts in light of all the circumstances. There is an exclusion for gross negligence or willful conduct. There must be actual exposure to COVID that caused the injury. Limitations on damages. I mean, this is a Chamber of Commerce wish list that is being pushed. Presumably, as we haven't seen any progress on the rest of a major piece of legislation, this will go away. But of course, depending on the election, it might well come back next year. Waivers of liability or exculpatory clauses. Easiest way to talk about these is to give some examples. If you decided that Florida was safe and it was time to take the kids to Walt Disney World, then you would have seen this sign as part of their travel information. An inherent risk of exposure exists in any public place. By visiting Walt Disney World Resort, you voluntarily assume all risks related to exposure to COVID-19. Help keep each other healthy, but presumably not liable. If you thought it was just big business, the persons who sat, or at least thought they were going to sit, it was later canceled, sit the Oregon bar exam would have had to sign this waiver. I knowingly and freely assume all such risks, both known and unknown. That's charming, even if arising from the negligence of the Oregon state bar parties, et cetera, et cetera, et cetera. And probably the most famous of all for the millions of you who attended or tried to attend but couldn't get in to the Trump Tulsa rally. This was on the website, and in order to get your ticket, you had to agree to that you would voluntarily assume all risk relating to exposure and agree not to hold the president or any others liable. So what are we talking about here? Well, these are waivers or exculpatory clauses. They are creatures of contract more than tort law. I guess some of us call those contort issues these days. Originally, waivers were universally disapproved. Now, courts generally approve them if recreational pursuits are the ones being excluded. Modern doctrine is pretty complicated with quite a few variants. And because of ill-advised doctrinal linkages to assumption of risk, sometimes one thinks these are just increasingly designed to confuse first-year law students. But if you look at the country, generally, very few states today just have an unenforceable rule. Most generally will enforce these provisions, but a very large number, while in favor of enforceability as a general proposition, will have what we call a public policy exception that I'll get to later, and others will require a specific use of what is being excluded being put in the language. So you can't just exclude liability. You have to say you're specifically excluding negligence or whatever. The New York statute is kind of interesting. It's the only one of its kind in the country. It is a blanket unenforceable with a list of things of places that you are not allowed to exclude liability in. These include pools, gymnasiums, places of amusement or recreation, similar establishments where there's a fee or other compensation. Outside, those are deemed to be void as against public policy and wholly unenforceable. So it's kind of like the old rule of about 40, 50 years ago. Otherwise, those clauses are generally enforceable in New York. If you create a sort of a flowchart as to how you go through this today to try and figure out whether it's applicable, or whether the defense does work or not after it's been pled, the key pieces that you have to look at are whether it's a matter of public interest. This comes from the old Tunkel case in California, and perhaps is better served by showing you a sort of a basic chart of the kinds of things that we've had courts saying are in the public interest, as opposed to those that are not in the public interest. And so if you want to do whitewater rafting or scuba diving or skiing, then probably a waiver is going to be liable. The other issue that I think is of importance here is where there is an attempt to waive an intentional tort or gross negligence. And as evidence or as an example of gross negligence, might I once again take you back to Tulsa, Oklahoma, where apparently Trump campaign workers removed the social distancing stickers from the auditorium that the rally used in Tulsa. And that, to me, would be a good example of reckless conduct in the face of the social distancing rules. So the recommendations, first, there is no evidence that a broad federal shield is necessary. Demands for such are not only unwarranted, but I think are more sort of typify the unconscionable opportunistic behavior by industries with very poor safety records, staring you right in the face, nursing homes. A broad federal shield is also unprecedented. Not only has there been no real traction for any sort of national medical malpractice litigation shields or anything. It's difficult to see this passing, getting a majority in Congress, even at the moment, and is going to be subject to a constitutional challenge. If there is to be a limited immunity, a targeted immunity, with limiting factors granted at the federal level, for example, to protect vaccine manufacturers and prescribers, then I think that has to be very carefully calibrated, and it should be accompanied by a federal compensation scheme. At the state government level, calls for broader immunity shields should be resisted, particularly where the conduct for which the shield is sought was not in mitigation of the pandemic, but actually increased the transmission. So congregate living facilities that had poor controls, I don't think deserve an immunity. And I think state policymakers would better serve businesses and other stakeholders, not with immunities, but with transparent data-driven guidances on reopening, and allowing those to inform the existing and appropriate reasonable care standards. It's reasonable care in all the circumstances. And if you have good data-driven guidance to inform that, I think everyone ends up in a safer place. Courts finally should interpret emergency COVID shields narrowly to avoid creating unjustifiably broad immunities, particularly concentrating on that arising from issue I mentioned. Perhaps there is room for a shield when they were designed to protect frontline workers during a limited period of unprecedented demand, stress, and shortness of supplies. But beyond that, I think they should be much more careful in giving broad interpretation to either the healthcare or the reopening shields, and they shouldn't show the deference to legislative action given to malpractice reform in too many states. And finally, to the waiver question, the exculpatory clauses, I think these should be denied applicability unless they explicitly exclude liability for failing to take reasonable care. And secondly, I think the list of services that have a general public interest, public political rallies, et cetera, should certainly not be viewed as recreational activities and should be voided by the courts. So thank you very much. We appreciate your attention.
Great, thank you. We have a few minutes for questions. You can enter your questions in the chat boxes and we can read those. Great, well with that, if there are no questions, that will conclude today's session. Please press
actually, Anna, if you don't mind,
go ahead.
Since there was a part at the very end of mine that I sort of cut off earlier to reserve some time for questions, and so I wanted to maybe highlight a couple of the recommendations that came out of my chapter as well. I think there are a couple of takeaway points that are worth at least stating in this conversation with regard to what we should be doing now to try to think about the use of the of government powers to restrict movement and what we can do essentially to avoid them from being needed as extensively as they were before in the earlier stages of the pandemic. And so just wanted to highlight, one thing that that our report recommends is that both Congress should fund and the CDC should take the lead in developing a unified national approach for rapid testing, contact tracing, and isolation based on positive testing, and allow for targeted interventions. And so we don't need, if we have a real scale up of testing, tracing, and isolating capacity, we won't need to do the widespread movement restrictions and widespread closures that we did before, because we can more effectively target who is exposed and who is infected. And we could have whatever restrictions need to be put into place be a more targeted approach. And so that's one recommendation that I think is really important, that we really haven't sufficiently moved on so far in the response to the pandemic. And similarly, there also needs to be a renewal of the congressional support policies and resources that were put into place under the CARES Act and other congressional legislation early in the pandemic, that much of which is now lapsed. So, supportive funding for people who lose their jobs or need to stay home because of a stay-at-home order or because they're sick. Having policies in place that, for example, protect against evictions, protect against mortgage foreclosure and utility shutoff, make sure that people can have extended unemployment benefits, things like that, which were put into place back in March and April, but are now lapsing. Those kinds of policies will allow people to stay home when they need to without having their situation made worse by the economic and social impacts of that requirement. And then finally, the last thing I'll mention is that in thinking about how, and again, state governments should take some of these steps as well. State governments are a little bit more limited in what they can do because most states, in fact, I think all but one, have a balanced budget requirement. And so states are going to be in a really bad position. And so supporting state systems from the federal level funding is going to be really important. And finally, the states should think through how to better target their restrictions. We know a lot more about how the disease is spread. A lot of states have already done this, and I think the states should look at what's best for public health and thinking about how to impose restrictions where necessary, but use the additional knowledge that we now have, including the effectiveness of masks and other kinds of information, to really target those restrictions in a way that they couldn't at the beginning of the pandemic, because now we know a lot more about how the disease spreads. So that's all I'll say. I just wanted to add a couple more points there.
Great, and we do have one question that came in. How do you think the Supreme Court is likely to approach Jacobson and police power cases as the pandemic drags on?
Well, it's a good question, and it's actually a hard one to answer. I think that the two cases that have come to the Supreme Court so far were both cases that involved a request for a preliminary injunction against a state restriction. And so because those were only evaluating whether the preliminary injunction should be granted or that the lower court ruling that it shouldn't be granted should be overturned, the standard and the analysis, and in fact the analysis was very limited in terms of how the court is thinking of Jacobson these days as it applies to police powers and public health. I think the four dissenters in both the South Bay United case and the Cavalry case indicate that there are at least four justices that are that believe that a broad deference under Jacobson, especially with regard to restrictions on religious activities, that they're skeptical of that broad deference. Whether other justices join them in subsequent cases, especially as there's a better understanding of the disease spread, and maybe the really broad, widespread restrictions are no longer quite as justifiable because we know that we can do more targeted things. It's possible that they will be less differential to Jacobson. That wouldn't surprise me if that were the case. But again, it's really hard to prognosticate because we haven't really had these kinds of cases in front of the court in a long time.
I would say that the kind of deference that we have seen in the older cases is gone. I mean, I think the article by Lindsay Wiley and who else was on that piece?
Steve Laddick, are you thinking of that piece?
Yes, clearly, I think putting forward a more modern view of Jacobson. The question is whether, I think, as you said, Lance, it will be particularly susceptible to First Amendment religious challenges. That was clearly Alito's message in the Cavalry case. So I think there's maximum exposure there.
Yeah, I agree.
Thank you. That concludes today's session. Please press the button underneath the video feed in Pathable to take the evaluation for this session. If you're in Zoom, you'll have to go to Pathable. And thank you for attending, and have a great rest of your day.
Thanks, everyone.